Welcome to today's webinar, Gestational Diabetes 2020, Best Practices for Healthcare Providers. We're so glad you could join us. My name is Amy Gohl, the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program. Just a few pieces of information before we get started. The speaker and planners have no relevant conflicts of interest to disclose for this program. An hour after the webinar ends, you will receive an email with a link to a post-program evaluation. Please complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Certificates of completion will be sent via email within 1 week. This program is being recorded and will be available on the Partnership's YouTube channel until November 16, 2022. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box, and our speaker will respond to as many as possible at the conclusion of the presentation. And now I'd like to introduce Mary Ann Meyer, our speaker for this afternoon. Mary Ann began her career in diabetes education at New York University Medical Center, New York City, where she served as a diabetes educator for 15 years. Since that time, she has held multiple positions involving diabetes education at Atlantic Home Care, Morristown Medical Center, and Tandem Diabetes. Mary Ellen also participates on the Medical Advisory Committee and as staff for Camp Nejeda. Oh, I don't know how to pronounce that. Nejeda in Stillwater, New Jersey. And that camp offers summer programs for children with diabetes. Thank you for joining us, Mary Ellen, and please say how I'm supposed to pronounce the name of the camp.
It's Nejeda.
Nejeda, thank you.
Yeah, Nejeda. So we're ready, huh?
We're ready.
All righty. So thank you, everybody, for joining me in this program. Oops, wait a minute, I'm sorry. Thank you for joining me in this program. One of the nice things about working with gestational diabetes is that these are some of the most motivated patients that you can work with. And it's generally a very happy time for them because they're having a baby. And then they get this diagnosis of gestational diabetes and they come to you sometimes really frightened. And being able to relieve them of that fear and give them a sense of control over this is very, very rewarding. So this was read. All right, so the objectives are to define gestational diabetes and describe the effects of pregnancy on blood glucose control. List 2 potential complications for the baby, 2 potential complications for the mom. And I would like to add to also identify the education that women need to help them manage and reduce the stress that this diagnosis brings. So what is gestational diabetes? It's when diabetes is diagnosed for the very first time during pregnancy. It affects how the cells use the glucose, and it's caused by placental hormones such as lactogen that cause insulin resistance. The reason that it's not diagnosed earlier in pregnancy is because there's actually increased insulin sensitivity early in pregnancy, and the insulin resistance doesn't really happen until the 2nd or 3rd trimesters. Somewhere around the 16th week, the insulin resistance does increase, and then it continues to increase exponentially during the 2nd and 3rd trimesters as the placenta grows and gives off more hormones such as the lactogen that I mentioned earlier. Resistance decreases again towards the 3rd trimester due to the placental aging. And at the practice that I have worked in, we used to say, oh, look, blood sugars are going down, the baby's going to be coming soon. So insulin resistance in pregnancy can result in an increase insulin requirements, up to 3 times what people would need, if women would need if they weren't pregnant. So gestational diabetes is increasing in the United States. And if you take a look at this slide, it's parallel to the obesity epidemic, with its greatest incidence in Asian and Hispanic women, its greatest increase in Asian and Hispanic women. And having taught gestational classes at the medical center, I can tell you that a good number of our groups, when we used to have groups, were Asian and Hispanic women, and also women of Indian descent. So what are the risk factors for gestational diabetes? Well, one is if you had gestational diabetes in a prior pregnancy. If you have been diagnosed with prediabetes, which means a fasting glucose over 99, you don't really have diabetes, but it's kind of a warning sign that it may be coming if you don't make lifestyle changes. So if you've had that diagnosis, if you've given birth to a baby weighing more than 9 pounds, and I have to comment here, my sister gave birth to an 11-pound baby, much to my horror, and we realized that she probably had not been checked for gestational diabetes and should have been. It's increased in multiple pregnancies. Also, if you have women have a BMI of over 25 or over 21 if you're Asian. This always makes me laugh because 25 sounds very young to me, but if your age is over 25 years old, that is a risk factor. If there's a family history of type 2 diabetes, this also increases risk. And then certain medical conditions, and as I mentioned before, some race and ethnicities. Excuse me. So how can women who are pregnant reduce their risk of developing gestational diabetes? So the only way to really do this would be if they have already been diagnosed as being overweight or obese. They can lower their risk by seeing a dietitian for medical nutrition therapy and perhaps losing some weight prior to the pregnancy. Women who have a normal weight, dietary changes don't particularly make any difference in whether they're going to, excuse me, develop gestational diabetes. If they don't change their diet, these are women who are overweight or obese. If they haven't changed their diet, 16 out of 100 women will be diagnosed with gestational diabetes. If they do change their diet, only 6 out of 100 women are diagnosed with gestational diabetes. So what are the health risks? So the health risks are both for the mother and for the baby. So the increased risks for the mom would include, during pregnancy, hypertension or high blood pressure, and preeclampsia. Preeclampsia is particularly a problem because it usually means that the mom ends up on bed rest or in the hospital, and sometimes having to have an early delivery, most likely by C-section. Post-pregnancy, if you've already had gestational diabetes, you have a risk of developing type 2 diabetes in the future. And that risk is approximately 40% if you have another child after the one that you had when you had gestational diabetes. Now, what about the baby? So during pregnancy and delivery, macrosomia can develop, which means a big baby. Now, how does that happen? So if the mother's blood sugars are elevated, that blood sugar or blood glucose passes through the placenta to the baby, and the baby's pancreas is working just fine. So any of us that have extra calories that we don't need and have a functioning pancreas will gain weight. And so that's what happens to the baby. If it's a very big baby, there's sometimes a problem with the vaginal delivery, and we have dystocia of the shoulder, meaning it's dislocated because the baby has a very hard time getting out. Lots of times when the baby is noted to be large, the mom is going to have a C-section to prevent a difficult delivery. Unfortunately, one of the things that can happen when a mom has gestational diabetes and the blood sugars are not well controlled is that sometimes there's sudden death in utero, which is, of course, a horror. What about the kids after being born of a mom with gestational? Well, the babies can have neonatal hypoglycemia. So what that means is the baby's pancreas has been revved up to give extra insulin to work on that extra glucose that was coming through from mom. and it's still revved up, and then they're taken away from their glucose source. So sometimes the babies have hypoglycemia and end up in the NICU, or the neonatal intensive care unit, for maybe a day or two. They have hyperbilirubinemia and jaundice, so jaundice of the newborn. They could have neonatal respiratory distress syndrome, and as they get older, there's an increased risk of hypertension, type 2 diabetes, and obesity. So when we talk about these risks with the moms in class, or if we're meeting with them one-on-one, we don't present them, of course, as you better follow your plan or else, but more as an opportunity for them to avoid if they follow the plan that they need to follow. I'm not a big believer in using scare tactics to get anybody to adhere to a plan, and especially in this particular area, I think it's a particularly bad idea. So how about the diagnosis? So there are a couple of different ways for diagnosing gestational diabetes. There are two different approaches. One is a one-step approach and one is a two-step approach. Both ACE, which is the American Association of Clinical Endocrinologists, and ADA, which is the American Diabetes Association, use the one-step approach. That involves giving the mom a 75-gram, 2-hour oral glucose tolerance test. And the criteria for the diagnosis would be if the fasting plasma glucose is greater than or equal to 92 milligrams per deciliter. At 1 hour, if the blood glucose is greater than or equal to 180 milligrams per deciliter. If the 2-hour result is greater than or equal to 153, then they are considered to have gestational diabetes. A positive diagnosis requires only that one criteria be met. So the American College of Obstetrics and Gynecology actually prefers the two-step process. And what that is a 50-gram 1-hour test, followed by, if necessary, a 100-gram 3-hour oral glucose tolerance test. So they give them first 50 grams, and the blood sugar after that, 1 hour after that, if it's greater than 140, then they move them on to the 100-gram test. So if they get the 100-gram test, the fasting glucose, if it's found to be greater than or equal to 95, 1 hour post greater than or equal to 180, same as the other test, 2 hours greater than or equal to 155, and at the 3rd hour greater than or equal to 140. Again, on this one, a positive diagnosis requires that 2 thresholds are met or exceeded. So what about treatment once somebody is diagnosed? So once they're diagnosed, they usually are sent either to a diabetes class, a gestational diabetes class, or they may just be sent to a dietitian to find out what it is that they have to do, what kinds of changes do they have to make. And the changes are going to involve multiple things. One change will be the change in activity, then medical nutrition therapy, which is probably the most important thing, glucose monitoring, which is the only way they really have of knowing whether they're doing okay, and if necessary, then we have to add pharmacology. So what about activity? So if the mom has been previously active, then they're expected to maintain the kind of activity that they have been maintaining before with modification as needed. I don't know how this woman is walking quite so quickly with a nice tummy like that, but many women do. And if they're able to do it and there's no pain and the doctor doesn't have any other reason for telling them not to, then they should maintain that level of activity. If it's a healthy mom who's been inactive, then the goal would be to strive for 150 minutes per week of activity. And that could be something like a walk. It doesn't have to be going to a gym or working out or obtaining a treadmill. So a 15 to 20-minute walk can potentially lower the blood sugar by 20 to 40 milligrams per deciliter. So that doesn't really sound like much, but when I talk about what the post-meal goals are, you'll be able to see that lowering a post-meal blood sugar by this much may be the difference between insulin and no insulin. So when we present this, oftentimes, at least in our area, the moms are kind of rolling their eyes and telling us that they work, 20 hours a day and they don't really know where they could possibly fit this in. And so we don't just leave them with, oh, well, figure it out. We try to work with them and have them come up with ideas of where they could put in bits of exercise. So I usually start out by saying any exercise that's more than you're doing now is a good thing. And then help them think about if they're working in an office, if they still do that. You can walk around in the office. They don't necessarily have to leave and go walk for an hour. They have to pick out little times of the day where they can get some activity. So they do need a lot of support in this. And if anybody is going to fail any part of the treatment, I would say that this is probably the part that they have the most difficulty with. So moving on to medical nutritional therapy. So this is where our dietitians are so important. Every person needs really their own personalized meal plan. So what happens when they call in to us to attend a gestational class is the person making the appointment obtains the woman's pre-pregnancy weight and current weight, and then the dietitian works out a meal plan for them that has 175 grams of carb at least, 71 grams of protein, and 28 grams of fiber that's also low in saturated fat. They have to divide this into 3 meals and 3 snacks. So believe it or not, an awful lot of women complain that it's too much food. Now, having been pregnant myself, I can't even imagine complaining that there's too much food, but some women just feel like they can't get all of that in. But we have to really explain to them that they need to keep the food going in to keep the baby's nutrition where it should be, and also so that they have extra stores of glycogen in their liver, which is a place that the extra glucose can be stored. 3 snacks people sometimes think are optional because for most of us, the word snack means you probably don't really want to have it. But when you're pregnant and have gestational diabetes, you need those snacks. So I usually try to explain to them that they're really just 3 smaller feedings. The reason that we don't want to deplete the glycogen reserves is because that can cause ketone production if the body starts to break down fat for fuel. And ketones have been shown to be detrimental to the development of the infant's brain. So we certainly want to avoid that at all costs. We teach women how to count carbs, and we have to teach them, of course, how to read food labels. And on the next slide, I will show you a couple of tools that we use. We explain to the patients that the carbohydrate is the primary source of fuel for the cell, but also has the greatest impact on the blood sugar. So blood sugar levels are also impacted by stress and illness. And glycogen, as I said before, is a reserve which, if depleted, will cause those ketones due to increased metabolism. Excuse me. So these are 2 of the tools that we use. The left side shows you the Daily Diabetes Meal Planning Guide. This is available for free from Lilly Diabetes. You can usually order it online, and they'll send you packages and packages of them. And what you'll find in here are listings of carbohydrates by group, like fruits or milks or breads, with the approximate serving size and the amount of carbohydrate. It also has a very nice description of how to read a food label. So this is a really good tool, and it's free. The meal plan on the other side is similar to what we use at our practice in that it has, for the person, their targets in terms of how many grams per day of each food group they need. And then we break it down for them as to how many carbs should you have at breakfast, lunch, snacks, and dinner, how many servings of protein, how many grams of protein. And all of this is explained to them, of course, by the dietitian. Then what we have them do is use that right-hand side where it's blank and have them fill it in for themselves using foods that they would normally eat for each of those meals, fill in what they think some good ideas are. Then we go over it with them to help them fine tune it if necessary, or to say, great job, you got it. And then they have to continue to refer to this because sometimes they just sort of forget what they're supposed to be eating. One thing that's not on here, which is surprising, is nighttime snack. There's always a bedtime snack. The bedtime snack is the one that women often want to skip because a lot of times they eat dinner kind of late. But that bedtime snack is what keeps their glucose overnight pretty stable. And it also allows for enough glucose to be available so that ketones don't develop. That's the longest period of time they have to go without any food. So that bedtime snack is very, very important. And let me stress that it's really personalized. It's not just here, this is your food, this is what you're supposed to eat. Somebody really sits down with them and makes sure that we have selected foods with them that they like. Not if they, sometimes they don't eat vegetables. If they don't eat vegetables, they don't eat vegetables. We can encourage them, but that's not something we would spend a lot of time focusing on. So it's primarily the carbohydrate and also the protein. And then if they are milk drinkers, then certainly the amount of milk that they need for the day is going to work its way in there as well. And milk has a deal of carbohydrate. The other thing that you have to be careful of is to be very culturally sensitive. We have a good number of women who are Hispanic and perhaps don't speak English, so we would meet with them individually using a translator phone. We have food lists for varied ethnic groups, and we usually bring those into class. So if somebody indicates that they eat Indian food or Spanish food, or they're vegetarian, then we give them, in addition to the daily meal planning guide, we give them the carbohydrate counts of the foods that they were most commonly going to eat. And I should also mention that handouts like that are available online. If you just Google, you'll find them. So how do we evaluate how their plan is working? So we usually will give them a blood sugar meter. The blood sugar meters are free for most practices. You can call your local rep and they will give you the blood sugar meters that you need. They don't really mind giving meters because that's not really how they make their money. They make their money on selling the strips. So they're happy to provide the meters. We generally are using a one-touch meter right now because that tends to be covered better by most insurances, but that isn't always the choice. There are some insurances that will not cover one touch, and then we might have the person come back and we'll change the meter and teach them how to use the new meter. There are people who don't have insurance, and the strips are very expensive if you don't have insurance. So Walmart and some of the other big box stores have meters that are their own brand, and they're relatively inexpensive compared to the branded meters. So some women will be using those, and we do keep some of those on hand because we know ahead of time whether somebody has insurance or not when they're coming in, and we don't want to put them in a position where they have to come to us and say, I can't afford to do this. So when do they test their blood sugar? They have to test 4 times a day. Now, this isn't the same as type 1. But this is for gestational only. So it's fasting when they first get up before they start eating, and then 2 hours after the first bite of each meal. We don't check them before meals because we're really more interested in the glucose rise than we are interested in where did they start from. And if you notice, I mentioned that they start after the first bite of each meal. So what we usually tell them is when the mouth starts chewing, the clock starts ticking. So their glucose goals are fasting should be less than 95, 1 hour postprandially should be less than 140, and 2 hours postprandial should be less than 120. Some practices will have the women check at 1 hour, but most of the time we're having them check at the 2 hour mark. So their goal there would be less than 120. 70 to 85% of women can control their blood sugars with lifestyle modifications. I should mention here too that we often encourage the women to bring their partner with them so that they have some support, so the partner knows what's going on. And quite frankly, sometimes teaching women how to check their blood sugar can be a little daunting for them. They're kind of stressed already by the diagnosis. And then the idea of actually sticking their finger really can just put them over the anxiety edge. I have seen women who just can't do it, and their partner actually does it for them until they get used to it. One of the things that's very important too is that they write down the results once they get them. They shouldn't be writing them down at the end of the day, because they're not going to remember what the results are, and they're not going to be accurate results. So things that we teach them so that they get accurate blood sugars when they're testing include, first of all, make sure the strips are not expired. Now, we don't give them expired strips, but the drugstore could possibly, if it happens to be a meter that's not ordered that frequently. So we always ask them to check that. They always have to clean their finger that they're going to use with soap and water or alcohol. There's no magic in alcohol. Soap and water works very well. It's easier sometimes to carry a few alcohol pads for when you're out and about and you have to do a test, but mostly soap and water is fine. Want to make sure that the finger is dry. Now, why are these two things important? Let's say that they didn't clean their finger and they completely forgot that maybe they ate an apple a couple of hours ago. And they stick their finger and they might get a very high reading. Even though the blood sugar is not high, it might just be there's a little apple juice on their finger. If the finger is not dry, then the blood could be diluted and they could get a falsely low reading. So clean and dry are very important. Once the lancing device is ready, they would stick their finger towards the tip, but a little off center. So all the nerves run right up the center of your finger. And so if you stick yourself in the middle, although you'll get the blood drop, it's more uncomfortable than if you stick your finger over towards the side. The lancing devices have settings on them so that you can dial it up if you're not getting a blood drop. We usually start on a very, very low setting, because most people, if they're doing the test correctly, don't need it turned up, and it's really not particularly painful if it's on a low setting. So what they often will do is they'll stick their finger and then they'll just stare at their finger expecting to see blood, but they don't, because they have to milk the finger. So what they try to do a lot of times is they'll be squeezing the top of their finger at the tip. Really what they need to do is to milk the finger from the base to the tip. I always tell them it's kind of like when you ran out of toothpaste and you're trying to get that last bit of toothpaste out of the tube, and then give it a squeeze once you get up there. And usually that will provide you with a good drop of blood. Then they apply the blood to the strip and immediately record the result in their log or on their log sheet, whatever the practice has given them. So one of the things that we have to be careful of is when we're teaching women this is to make sure that they understand that even if they get high blood sugars, they cannot start cutting back on their carbohydrates. Sometimes women figure, well, if I didn't eat as much carb as they told me, my sugar wouldn't be as high. But the carb is nutritionally necessary. So we have to figure out another way to get the blood sugars down if they're a little bit high. So the women are instructed that if they have 3 blood sugars in a week that are above the targets that we have given them, they need to let their doctor know. So the doctor we're talking about here is either their OB or their high-risk OB. But they need to be notified, because although we provide education, we are not managing these women, at least in the education center where I work. They still have their own OB who has sent them to us for education. So what if the meal planning and the exercise don't do the trick? Then we have to start talking about pharmacologic therapy. So the first choice for somebody whose blood sugars are elevated and needs treatment would be insulin. And the reason for that is because insulin does not pass through the placenta to the baby. Women generally are appalled at the idea of having to go on insulin, and we see many tears, and that's understandable because, again, this is supposed to be a happy time, and now we've given them another job, and people come to us with all kinds of ideas about insulin that require that we reassure and educate them. So the first insulin probably to be started, especially if the fastings are high, would be a basal insulin. And the basal insulin that's used most commonly would be Levemir, because it's approved for use in pregnancy. NPH can be used as well, but it's not as good an insulin as Levemir in controlling blood sugars, and it also forces people to have to eat on a very specific schedule, so we try not to use that. The OB would probably prescribe the insulin and probably send the woman back to us to teach her how to use it. If somebody with gestational diabetes requires insulin and they decide they want to be seen by an endocrinologist, they most certainly can be, but most of the time it's managed by their obstetrician. The dose of the insulin is usually prescribed on a weight base, excuse me, usually 0.2 units per kilo, up to 1.5 to 2 units per kilo per day for obese women. If they need more than just basal insulin, and now because their blood sugars after meals are high, they also need mealtime insulin, then the calculation is divided so that 50% of it is basal insulin and 50% of it is what we'll call bolus insulin, or shots with the meals. We don't usually have them take shots with their snacks, but instead we'll move the carbohydrate out of the snack so it's not causing a rise in blood sugars in between meals, and move that carbohydrate into a meal so their snacks are more protein based, and then they don't need to take another shot. OBs seem to like to use regular and NPH more than, say, an endo would, and it can be done, but women are smart and they do ask questions, and if they decide that they don't want that therapy because they do realize that it requires eating on a schedule, which they sometimes can't do, then, as I said, they might come to the endocrine center and go on basal bolus insulin with rapid-acting insulins and Levemir. So if we can't use insulin and we still have inadequate control, the second choice would be glyburide or metformin. Not that many years ago, we used glyburide, or doctors use glyburide pretty regularly, but what they have found now is that it does cross the placenta, and it also causes neonatal hypoglycemia and macrosomia more than insulin or metformin. Metformin doesn't do a lot to control blood sugars, but some doctors will still use it. That also gets passed to the baby. If they're on metformin for polycystic ovary disease, that should really be stopped by the end of the first trimester. So if you do use metformin, the advantage is it has a lower rate of neonatal hypoglycemia because it doesn't actually make the pancreas create more insulin. There's less maternal weight gain than on insulin. The umbilical cord level is higher than maternal levels, or as high. And they did find, though, that 7 to 9-year-olds were heavier and had a higher waist to height ratio if their mothers have been taking metformin than those who were exposed to insulin. Excuse me. If it was used to treat PCOS pregestationally and gestationally, 4-year-olds had a higher BMI, increased obesity. Excuse me. And there was really no benefit in preventing spontaneous abortions of GDM, and no need to continue once the patient with PCOS becomes pregnant. So why do we still see patients on these medications? Well, sometimes it's because insulin is neither safe nor affordable. If you do not have insurance, insulin is not something most people can afford. Unfortunately, it is still extremely expensive. So we have some insulins that can be ordered that are mixtures. They're less expensive. Walmart has its own insulin that is a mixture of a rapid acting and a longer acting. And for some people, this would be an affordable measure. But if they can't afford even that, then we have to use the other medications rather than not use anything. The glyburide is generally very cheap, and some stores even provide it at no cost. For some people, because of a language barrier, we have to give them something that is easier for them to manage. Sometimes women can't comprehend the correct use of insulin, or the risk of them using it is greater than the risk of them not using it because they could either under or overdose. And then there are also cultural influences. Certain cultures see insulin as a really terrible thing, and they really don't want to take it. So what about low blood sugar? Is low blood sugar a concern in the woman with diabetes? Well, not generally. If they're on insulin, it can be, but women who are pregnant generally have much lower blood sugars than the rest of us. A blood sugar of 60 is normal in a pregnant woman. We don't usually treat low blood sugar unless the blood sugar goes below 60. So if mom's on glyburide or insulin, then we do instruct them about low blood sugar. We explain the reasons that they could go low, which would be skipping a meal or miscounting carbs. That we go over the symptoms, which would be shakiness, headache, blurry vision, lightheadedness, feeling faint, cold sweat, and we explain to them how to treat it. And the way they treat it is with 15 grams of rapid-acting carbohydrate. We generally try to have people use something like glucose tabs because if you're carrying around Skittles, it's very tempting to munch on those. So we prefer that they use something that works, but isn't necessarily a tempting snack. The other option would be those little tiny juice boxes that the little ones get these days. They're about 4 ounces of fruit juice. It does not have to be orange juice. It can be any flavor fruit juice at all, as long as it's juice and not one of those juice drinks. When going back to the blood testing, I neglected to mention this. When the doctor orders strips for the patient, he needs to order or she needs to order 5 strips a day. But if somebody goes on insulin, they have to up those so that they would have maybe 8 to 10 strips a day. And the reason for this is because if there's a low blood sugar, you need to check to see if you're low, then you need to treat it, then you need to recheck to make sure you came back up again. And if you're really low, you have to treat it again and recheck again. And so we don't want to add to the stress of this by having patients not get enough strips. So we usually tell them how many strips they're going to need. So when they go back to their doctor for that order, the doctor knows how many to order. Excuse me. So one of the things that we want people to do is consistently treat their lows with the same thing so that they know what the result is going to be. So one of the things to consider, especially where you have many different people living, is the ability to provide culturally sensitive education, which I've mentioned before. So there are a few things. We have to find out how the patient identifies himself culturally. We need to find out what kind of food they eat. We have to find out whether they actually understand English well enough. And I will often say, is English your preferred language? Would you like to learn this in another language? Sometimes they're very relieved to find out that they can learn it in their own language using the translation phone. We provide materials in their language as much as possible. And we try to personalize their meal plan to what they're used to. Sometimes we have to involve the family as well because the woman may not be the meal preparer in that home. Sometimes there's a lot of extended family and another person, perhaps the woman's mother, is the one that's doing the cooking. And so that person also needs to understand what we have to have the women eating to keep healthy. So then we can talk about the 4th trimester. And what does that mean? That means the baby's arrived and the mom is now thinking about what about the future. So gestational diabetes can represent previously undiagnosed diabetes. There was a very small number of women where after the baby is born, the diabetes doesn't really go away. And it turns out that they actually have had type 2 all along, or in a rare instances, they have MODY, which is maturity onset of the diabetes of the young, or they even have type 1. I've seen it a few times, but usually it does just go away. So anyone with a history of gestational diabetes has to be tested again 4 to 12 weeks after the birth with another 75-gram glucose tolerance test, the one that was used earlier, to make sure that they now meet the standard blood sugars. They can't really use a hemoglobin A1C as a diagnosis tool with postpartum because a hemoglobin A1C represents average blood sugars for 2 to 3 months, and the testing takes place before that. So a diagnosis of diabetes can be made with an A1C of 6.5, but again, we can't really use this, at least at this time, in order to decide whether or not somebody still has diabetes. So because they're at risk for type 2 diabetes, they do need an A1C done every 1 to 3 years. And in order to reduce their risk of developing type 2, they have to follow a healthy eating pattern. We do encourage them after the baby's born, they can't get the weight off, to come back and see the dietitian for a new meal plan for non-pregnancy, or go to Weight Watchers or a program that helps them get the weight off. They have to use Metformin if they have pre-diabetes, and that will help delay the risk of developing type 2 diabetes. Breastfeeding actually diminishes the risk of developing type 2. They're encouraged to continue to be active and maintain a BMI less than 25. Women who breastfed had a median time to developing type 2 as 12.3 years, compared with 2.3 years among women who did not breastfeed. In the future, women need to consider on their second pregnancy or third or whatever it is, making sure that they get themselves down to as close to an ideal body weight as possible before they actually decide to get pregnant. In addition, they may end up being tested sooner than they would have been if they didn't have gestational diabetes beforehand. Sometimes the doctors will actually do the oral glucose challenge a couple of times a few weeks earlier than they would normally, just to make sure that if they do have it, that they pick it up right away. And even if they do develop it again, it's not necessarily going to be treated the same way. It's interesting. Some women, their first pregnancy had to be on insulin, and then the second pregnancy, although they have it, they were able to control it with diet and exercise. So every pregnancy or every gestational pregnancy is a little bit different from the one before, or can be. So as far as the references are concerned, I have one extra reference to mention that's not on here, and that's the AADE, which is the American Association of Diabetes Educators practice paper. It's entitled Gestational Diabetes, and it was published in May of 2018. So as I was looking through many of these references, for instance, the first one is kind of the gold standard. It's the diabetes care supplement that comes out every year. I found that the AAD practice paper, for people who are not as familiar with gestational diabetes as some of us are, is an extremely understandable step-by-step instruction guide, so to speak, to help you understand what to do for your patients. So I understand too that not everybody has an entire education center that can be devoted to this. I would say that if you were going to send the patient to one person, it would be to a nutritionist who is a CDE, and that would be the most useful for the patient. So women with diabetes, gestational diabetes, years ago didn't know, and many of them lost their babies, but we know so quickly now, and it's incredible how many women actually do have it. So we see, I can't even tell you how many women, before COVID, we were seeing a class or two every single week that was full, and sometimes a waiting list. So it is out there, and it's important that women are tested. So that's it for me. If anyone has any questions, I think you can submit them.
Oh, there she is. That was wonderful, Mary Ellen. Thank you so much. I think I've told you before that I always had difficulty with diabetes in school, and this was really very enlightening. I appreciate it. We do have some questions in the question box, and I encourage those who are still on the webinar with us that if you have questions to please put them in. The first question is about Metformin, and this person is asking if she had heard that there was a recall on Metformin.
Yes.
Can you shed any light on that?
Yes, certain brands have been recalled, but it happened actually quite a while ago. And so the brands that are out there now that are still in the pharmacies are the non-recalled medications.
Thank you. What is the target blood sugar 2 hours after a meal?
For somebody with gestational diabetes, the target is to be 120 or less 2 hours after.
Thank you. What can you say to a new mother to encourage her to return for the postpartum glucose check?
That's actually kind of the role of the obstetrician, is the one that would be saying that, or also the nurses in the hospital. But I would just say to them, look, we want to make sure that it actually went away, because if it didn't, we want to be able to help you to be healthy. And it may be that you just need a meal plan and a little activity. But I would encourage them strongly to come back for their own health.
And here's another question. What are 2 risks to the mother if blood sugars are not controlled during pregnancy complicated by gestational diabetes?
The 2 risks would be preeclampsia and the possibility of having to have a C-section because of a large baby.
Now, I know this wasn't exactly the topic of this talk, but we did have one question about how care for a mom who had diabetes before she gets pregnant would differ from somebody with gestational diabetes.
I can say that that would be a whole separate program, but in general,
next year,
in general, it's more aggressive. So if the person had type 1 before, it's a lot of work for the mom. They are testing, they need to first of all have an A1C that's pretty low before we, quote, give them permission to get pregnant, if we get to have that conversation. We will often have to get them quickly regulated down to pregnancy goals. Lots of times we put them on insulin pumps so that they aren't taking as many shots as they would otherwise be taking. They usually are wearing a continuous glucose monitor. And if they're not, they could be testing 10 to 12 times a day, which becomes incredibly annoying. If someone with type 2, we often will have to put them on insulin because whatever oral medication they were on is not safe for the baby. And they also would not get the degree of control. So they too would have a lot of blood testing to do. Continuous glucose monitors are not exactly approved for pregnancy, but someone with type 1 is probably wearing it already. And somebody.
Okay, well, I think that since we haven't been able to connect with our speaker, we're going to have to end today's program a little bit early. But I would like to thank Mary Ellen Meyer for coming on and speaking with us this afternoon. And I will forward the remaining questions in the question box to her, and hopefully we'll be able to answer those offline. I'd also like to thank Monica Smith, who's working the back end of today's program. A reminder to all of the folks on today's webinar that you'll receive an email with a link to the post-program evaluation. That should come within the hour. And you'll receive your certificate of completion if you take the evaluation, and the certificate will come in the body of an email, and that should be to you within 1 week. This Thursday, November 19th, we'll be presenting our next webinar, Screening, Diagnosis, and challenges in kids with diabetes, simple things that can change and save lives. For more information about this program, please go to the Professional Education tab on the Partnerships website, www.partnershipmch.org. We also offer on-demand recordings of many of our programs, which will be listed there as well. Hope you can join us at our next educational event.